Dr. Evans a question about
Yes, ma'am.
therapeutic radiology treatment. When a woman is told you have, like Mrs. Duncan was told, you have breast cancer, you know, you're 37 years old, you have 3 young children and a husband and a future career.
Right.
And you have to get, but she was lucky, her cancer was early. She was just approaching stage 2. For a woman who is told she has stage 3 or stage 4, what can radiation therapy do for her? And how do you go about setting up a treatment regimen?
Right, so that's a great question. So what radiation really can offer is we can deliver radiation to the breast, or in women who have had a mastectomy, to the chest wall and some of the lymph node bearing areas, like the lymph nodes underneath the collarbone. And what the radiation does pretty reliably and reproducibly is reduces the risk of a recurrence in those areas. And one of the most important things that we've discovered over the years is that for every 4 recurrences that we prevent in the breast, we save 1 life from breast cancer. So it is a life-saving treatment. It is something that's important as a part of your care. And how we really go about that is when a woman is diagnosed with breast cancer, undergoes surgery, maybe she also requires chemotherapy. Those would happen first, typically. And then when she comes to us to discuss radiation, we sit down, we talk about the radiation, we talk about the risks and the benefits in her specific case to let her know what her risk is going forward were she not to have radiation, and what sort of benefit the radiation can provide in terms of risk reduction. When a woman decides that she does indeed think that risk reduction is worth it for her, then what we'll do is a radiation planning session. And what's involved with that is basically it's a mapping. It's where we sit down and design and customize the radiation for your specific size and shape. As part of that session, we'll do a planning CT scan or imaging where we'll be able to see exactly where the radiation needs to be given. And also we do sort of a virtual reality thing where we draw on any important organs nearby. As women, we're curved, we're not squares, so the breast sort of curves around the wall of the chest, and as a result of that, oftentimes there's a little crescent moon of lung that sees some radiation, and on the left side sometimes that includes some heart as well. So what we'll do is before someone ever gets a radiation treatment, we will map out the radiation and we will determine the dose of radiation that would go to nearby heart and lung for the left side, or just lung for right-sided cancers, and be able to look at that before you ever get a treatment, and we'll know how much radiation will go to any nearby bystander organs, and we'll be able to look at that. And I always ask myself, is that good enough for my radiation plan? And if the answer is no, then before you're ever treated, we say, all right, what can we do to make this better? And we change things and modulate things so that it's a safe and effective treatment plan.
Okay, how do the 3 of you work? So patient A walks in, and like Mrs. Duncan said, the doctor sent her for a mammogram, and then they did a biopsy and found out that, now who would have done the biopsy?
It would be me.
You would have done the
Radiologist
biopsy.
would do
Okay,
it.
so the patient comes to you, the doctor says yes, he sees or she sees a lump that definitely looks like cancer. You perform the biopsy. After you do the biopsy, what next? What happens? How do these 2 get involved, or do they?
After we do the biopsy, we will send the tissue off to the lab.
To the pathologist.
Yeah. And then we confirm that in fact it is a cancer, or it's not. And then we will call the patient's doctor with the results. And then it's really up to the patient's doctor, whether, we were discussing this earlier, whether they would like us to contact the patient and give them the results, or if their primary doctor would rather contact the patient with the results.
Okay, so let's say the primary doctor, her gynecologist called her and gave her the results. So now let's jump to a treatment plan. Is the gynecologist involved in the treatment plan at all?
So what generally happens is, at any stage, the radiologist, the gynecologist, the primary care doctor when faced with a diagnosis of breast cancer, in general, will refer to a surgeon. Oftentimes, they'll refer to our multidisciplinary team.
Yes.
So our team actually is more than just the three of us. One of the key elements is a medical oncologist. So we work very closely with our medical oncology colleagues. And you were talking earlier about stage 3 and stage 4 cancers, yes, where the medical oncologist is really one of the critical players.
What does he or she do?
So a medical oncologist will treat cancer with medicine. And whether that medicine is chemotherapy or hormonal therapy that will block estrogen and progesterone, we talked a little bit about how many cancers are fed by estrogen. Well, the medical oncologist in their armamentarium has pills that will block estrogen. There are now targeted therapies, so therapies that are delivered to block certain receptors like HER2/neu. And so as a multidisciplinary team, we really formulate how this patient will be optimally treated. So they'll be seen by us. We will do a history, we'll do a physical, we'll establish what we think is their clinical stage. We may do additional tests to make sure that the cancer hasn't spread anywhere else. If it has,
and that's where the lymph node thing comes in.
Well, not quite. If it's spread outside of the lymph nodes, if it's spread to bone or liver or lungs, that's stage 4. And in stage 4, the medical oncologist really is in the driver's seat. All of us back up the medical oncologist. Anything short of stage 4 is really a multidisciplinary conversation. In early stage breast cancers, so stage 1 for example, surgery is often the primary driver. So the patient would meet with the surgeon. We would discuss the surgical options. You know, you could have a partial mastectomy, what some people call a lumpectomy.
Yes.
You could have a mastectomy. You could have that with reconstruction at the same time.
And a mastectomy means taking off the breast completely.
Taking off the breast completely, but it doesn't necessarily mean that you're flat. So we have plastic surgery as part of our team. And oftentimes, you know, while I'm removing the cancer, the plastic surgeon is right in the operating room right with me at the same time rebuilding it. So patients can have this really team dynamic playing at every stage. Once the cancer is out, and sometimes even before the cancer is out, then the medical oncologist will get involved. Do we need to give chemotherapy to shrink the cancer before surgery? Or after the surgery, can we give chemotherapy or other medicines to make sure that this cancer doesn't spread anywhere, doesn't go anywhere? And then we get Suzanne Evans involved and her team in radiation to give radiation to make sure that this doesn't recur and that, you know, this patient can maintain a cancer-free lifestyle. And we involve our survivorship clinic, which is another thing we have at Smilow.